computer. Then you can just set your cell phone beside your computer and video your keyboard area for me. And you don't have to worry about the computer being tilted or looking down unless you have a webcam that you can move around. Okay. Friday, but I need to see you first. Capital Frida. Now I don't see you. Where are you at? Okay, logged out. All right, so as soon as we get off the phone, just go ahead back in and then mute yourself on your phone so we don't hear anything. And then you're good to go. You should be good. You're welcome. Bye.
Hello?
Professor, I'm finally done. Oh, sorry, there's someone else.
Did you submit yours, Marcel?
I thought I did. Let me double check.
Okay, I haven't checked you. I was just checking. We got 1 minute if you were looking it over. I'm going to check on the grade book and make sure it's submitted.
Okay.
I sent you a message. I don't know if you saw it.
I did see it. I can't comment on grades to the public in the forum or anything, but we can chat after. I still have to grade them though, because there's some fill in the blanks that are not graded. And then it'll be updated in the grade book.
Because I'm right on the verge, bro.
Me either. Yeah, I gotta get on.
Hey guys, so I haven't got to grade everybody's. I'm still trying to go through them. So when we review, just keep that in mind that your grade will update once I've graded all the fill in the blanks. If you have anything that you want to discuss that was confusing, a question you just want to talk about why you missed it, type it in the chat and then we can review them. Sarah, everybody's number 18 will be different because it's scrambled. So you just need to type kind of what was asking or about so we can discuss it. Yeah. Yeah, I got a couple of people message me afterwards about the second guessing. That always happens. I got a couple of people asking about that image F1, so I'll pull that one up and we'll look at it. One of them was asking the projection, and one of those questions was asking the position.
That's what I thought it was at first, and then I saw the other one said positioning. I was like, okay, no, that was right about.
Yeah.
Yeah, all the other ones were right. It was just that one.
Yeah.
Yeah, one said RPO instead of RAO, so I went back and fixed that. I just assumed everybody that picked RPO was trying to pick the best, closest
I
choice.
picked PA because I was like, okay, maybe she means projection.
Right.
Gotcha. Okay.
If that
I'll go
makes
back and look
sense.
at everybody's on that one. Yeah.
There was one where I just like completely misspelt the word and I was like, okay, well, I need to do better than that. Like it just wasn't, the whole thing was weird. I knew the answer and you can tell that I knew the answer, but the last bit of it was not right. And I'm like, okay.
Change the answers. Image F. Fill in the blank about Marion in the lab. Yeah, I got a couple of different things on that one. Most people that I've graded so far got it right. So when you marry and we say, once you marry, don't get divorced, what we're talking about is when you move the height of the tube up and down, you need to match the height of the bucky to it. So that little line, that laser line that comes out. I've got a couple people joining. So when we say marry, we're matching. You can describe this as matching the central line, the center of the light, to the center of the IR or the center of the bucky. Either description, something like that. You can also do it in the table bucky. The bucky slides up and down the table. So when you move the tube up and down, you always want to make sure they're matched or married.
Oh, that's the question I got wrong too.
Yeah, I got that wrong. I just said spend all your time in the x-ray room. That's where you're going to be at. When you say marry.
I was like,
You're married to the x-ray room. That's
Yes.
That's also true.
that question irked my soul. I was like, what is this?
Position is not an option. All right, so on the one that was the wrong RPO, LPO choice, I went back and changed it RAO, but some of you might have already fixed and picked it. Some people went ahead and picked RPO, but if you put the projection, I'll just give, if you got the projection correct, because that one was confusing because the RAO wasn't there at first.
When it popped up at the end, it was like option E was LAO or option F. And I was like, wait, there was no option E or F. There was only A, B, C, D.
There should have been.
For all those, I
we
only saw
reviewed
4
it.
of them. Yeah, it only shows 4.
Kind of was reviewing all of them. All of
Are we talking
you.
about
Yeah, there was 3 or 4 with the position or the projection. One was lateral, one was AP, one was PA, one was
yeah,
R.
they didn't have
Yeah.
left, so I put LPO because I know it was oblique.
Yeah, but he was the right. I mean, there was one that was a left oblique, I believe, too, that you had to fill in the blank on.
Yeah,
So all of those had the same answers when you reviewed it, hopefully. I had all the answers written out for you for all the projections and positions. So when you reviewed it, you could know all the pictures.
it didn't give me a choice for left though. On for my test, it was 57.
I'll go ahead and pull up the image and we'll talk about it so everybody's correct on the picture.
Yeah, it says
Yeah.
For image letter F, where
So tactile, auditory, visual for learning styles, I will mark you correct. I have to go back and fill in the blank ones
Oh,
and manually
yeah.
grade them.
Is it tactile?
Lower
Okay.
energy on the EMS spectrum. Sorry, go ahead.
Was the correct answer like cognitive and
No, learning styles is either you can say kinetic or doing it. I would have took the description hands-on. Visual or seeing, having to picture images. Some people are better at that. Auditory is hearing or listening. If any of that if you put down, you would have got credit for that.
I put effective and the
So
cognitive
those are
because they are.
domains
Yeah, that's
of
what I thought.
learning. Affective is your behaviors. Cognitive is your thinking domain. That's what we do with the test here. We're testing your cognitive skills, and when we see you do it in the lab, we're testing your affective. Or, sorry, your
I think I was
Psychomotor.
confused because like in the book, the definitions of those words says that it's like 1 out of 3 learning. Like I'll read it to you. It's just
the
I put
3
cognitive.
domains of learning.
right. That's why I think that because I like memorized those definitions
Yeah.
and I was like, okay, like
I
that's
was
it.
wondering why people put that on that one. So the learning styles quiz that we did is your different learning styles, how you learn. But the different domains of learning is different.
I got it right, but I put cognitive and I also put I can't say that word.
Yeah.
Didactics.
So that's just meaning that we're teaching you didactically instead of clinically. So anything at the school is didactic learning. Anything when you go out to the hospitals is your clinical education.
Okay, because I also put cognitive as well.
Yeah, so you will not get that one credit. I don't think it would have marked you right. It probably left it blank.
No, it marked well. Yeah, but I put cognitive as well.
So the answer for the learning styles, though, is hands-on doing learning style. Listening, you like to hear it. People that can do auditory books or record lectures and listen to them. Visual is seeing it, so pictures help you if you're a visual learner. So those are the learning styles that we did on the learning styles quiz or review.
I also
Low energy.
in
Could that
clinical.
question be like reviewed? Because I just feel like the way it was worded, there's only like one key word that can differentiate it from either it being a major category of learning or a different style of learning. So I guess just that one word that like screwed me up.
What word?
Because in the question, it says like, what is the different styles of learning, right? But
Yeah, I think so. Or the learning styles. Let's see what it said. Week 1. Let's see how it was worded. Because the domains of learning are cognitive, affective domain.
Psychomotor.
That's
Psychomotor.
and see how you guys could get those two confused. Where's the quiz? Exam 1. I was just trying to make up a question on what we did the other day whenever I made that question. Why we did the learning styles survey. Let's see. I want to pull up that picture too.
Professor, the exam, all the exams are not weighted equally.
No, this is the lowest weighted exam for your percentage. It's on your syllabus.
Oh, man.
Hold on, I don't see it yet. Okay, lab direction. So I'm looking for the low energy. I think I said below visible light or something like that would be radio waves, heat, or thermal or infrared. I would have took, I think a couple of people put heat, microwaves, the laser.
Is radio
What
okay?
about gamma?
Gamma's on the high end. So the low end question that somebody asked about, the lower energies are, I think the actual fill in the blank asked for it to say something that's below visible light on the spectrum. So anything on that low energy area or to the left.
So
Yeah,
radio is
I
fine.
was
Okay,
having
cool.
a hard time, like when I was studying last night, trying to figure out like how do you read that graph? Like I
Yeah.
can't.
So we'll look at that again.
Oh man, it changed my answer on some of them. Oh
The
my
high
God.
energy side or the stronger wavelengths that become ionizing are after ultraviolet light, which is X-rays, gammas, and in-space radiation.
The sound waves will not get credit.
Don't know why. I'm not finding that question now. What is it that you're asking about getting credit for it, or you're thinking what you put was wrong or right, maybe?
Sound waves?
Sound waves. Yep, you'll be fine.
Okay, you're awesome. Thank you.
Professor, it says basically whenever you're doing projections on the skull, it changed my answer. Obviously, it's not using a skull phantom, and
That is the answer.
again,
right?
I got cursed with the
Okay, there it is. What are the different learning
it's
styles?
on classmate, and I knew that, and I don't know why. It
Yeah, you
changed my
cannot expose on a person. We can only use the phantom.
Oh,
The different
yeah.
learning styles. What are the different learning styles? The domains of learning. I'm trying to think. Faculty cookies. I want to, while we're sharing screen, look at the picture of the guy. All right, so
Excellent.
scroll down. Back against the board or table, the path of the beam's coming from the front, so that's an AP projection. This one's turned around, so a PA projection. Both of these are lateral projections. This C is right side touching, right lateral position. D is left lateral position. These are facing the board, so posterior is the projection, a posterior oblique to be more precise. The position on this one is the left side's touching, so LAO. This one is RAO. The choices on that question when it was asking letter F at first did not have AO, it had PO. So people picked it because it was the closest to, and then some people put PA. So if you put a PA for the projection or the RPO, which I fixed and changed it to RAO, which it should have been, you got correct. So those would have been the only two that were close to being correct. But the question was position, not projection. So that one I'll go back and fix for everybody.
And there was one where it was fill in the blank. And I wrote out right anterior oblique, and
Right
I marked it
anterior.
wrong because I didn't put RAO.
No, I'll fix it. I've already fixed it. I think maybe on a couple people's did that.
Okay.
So I'll have to manually grade all the fill in the blanks. Now let me go back to the question box and see what else we got.
Hopefully, I'll be one of those who get it changed.
As long as you had it right on the fill in the blank, you're good. So the X-ray levels on the graph. That was a tricky question. EMF sound, we said yes. Radio wave sounds good. Same. Oh, you got a little abbreviation thing going for the radio waves, Michael did. So on the left side of the spectrum, when you look at the numbers, I said you don't have to memorize them, but the math of them are lower. When you go to the high side of the spectrum, they're higher. So it also has a flow of a wave drawn out in the picture. So when the waves are far apart, they're considered low energy. When the waves are close together, like at the beach, knocking you down a lot, those are higher energy. And we're going to talk more about the energy in the EMS spectrum in physics. So that was just to kind of give you a intro to the EM spectrum and know the difference between ionizing and non-ionizing wavelengths that are on there. So
Professor,
ionizing is the ability to remove an electron. That can cause damage, biological harm to us. So that's why X-rays and gamma rays are considered harmful, and we don't want to just do X-rays on everybody, and that's why we can't expose each other in the lab. So EMS means the electromagnetic spectrum. Yep.
Professor, when it says list 3 other certifications by the ARRT, I got the BD, and I knew this just from memory, but I put also BS for breast sonogram and CI for cardiac interventional radiography.
Yep, as long as they're one of the registries that they offer, you will be marked correct. Yep.
Awesome, awesome.
Yep.
Thank you.
And visceral instead of visual. Yeah, Elizabeth. Yeah, I think I'll give you credit for just a typo error, I guess. Your mind was typing funny.
No, you don't have to. I'm actually really embarrassed about that. Like, I don't.
Oh, okay, I thought you were trying to say you meant visual, but you accidentally typed
In my
visceral.
head, I meant visual.
Okay.
I thought visceral meant visual, and I
No.
was more like profound word. I don't really know.
We forgive you.
It's Michael.
She just
I
exposed
think
you
that's
to the whole class on that choice.
I think I missed out infrared too, so.
I think that's all. I think I didn't miss anybody's questions. All right, guys. So first exam over with. Yay. Congrats.
Bye, everyone.
Now, you will see these questions similar, something like that, probably on the next exam, because we only have a few days next week. I'm trying to go back and forth on how many next week's exam. It may be a shorter exam, 50 questions instead of 100. We'll see. We only have today what we're going over, Tuesday and Wednesday.
Are we able to go back in and print the exam out to have for a study guide?
No.
No.
Do you know
So
when those
you
might be
missed what I
posted?
said before we started the exam. If you weren't logged in or didn't have your sound on, I will post that in an email to you guys to have. You can't share information from tests or quizzes, print them out, save them, screenshot them, take pictures of them, or anything. The only time we can discuss it is now when we review it to make sure you understand what you got right or wrong, because you will see similar type of questions in future classes from different instructors on this information, and you don't want to just memorize questions and stuff. You want to write down what you got wrong, the topic or the area that you need to go back and study to make sure you know it, because just looking and memorizing questions is not going to help you on the registry, because you have to remember this for 2 years, almost 16 months. So what we're going to do now is look at what we need to know for next week a little bit, because we have a 3-day weekend coming up. Yay. Try to figure out how to get this off of the screen big right now. With our career, we have an ethics committee. If he was to have wrote the ethics committee ahead of time, maybe they would have promoted and let him take the exam, but then he never furthered it anymore. But with us, if you have something on your history and you declare it before you take the exam, you can go above the ethics board to get permission to sit for the registry. While you're in the program, if anything happens, driving and drinking sometimes happens to students, or any charges that might violate the code of ethics, you should talk to your program director. You don't have to tell us. You don't have to tell your classmates. You just want to make sure that when you get done, you're going to be able to sit for the registry so that you can apply to the board for your ethics board review if you need it beforehand. I don't know what all constitutes needing to write into them. That's Miss Dean's job. But I do know when I sat for ARRT meetings, they said some crazy things that got approved, like peeping Toms. I'm like, you let them take and go work in the hospital now? Some of the people who passed the ethics board to sit for the exam, it was crazy. So as long as you are done with your, whatever your sentencing was, finished it, it's gone, you've served your whatever, and you go before the board, they will probably approve you to take the exam. Yes, everybody's supposed to be at home right now anyway, so we shouldn't have any issues. Drinking and driving issues.
I'm in the car.
So all of those ethical codes, we sign off on them every year when we renew our license. So you're just signing off that you haven't violated any of them. So you want to make sure you know our rules of ethics, our code of ethics. We're going to skip over to page 304. So if you run into, doesn't happen too often, I don't know, maybe I'm just like, don't think about things as being an ethical dilemma too much. Some people might think more about it than others, and you might run into them in your career. I mean, like I said, the examples I gave are some that I know I have had happen, and plus I worked in the prison, so I kind of was used to working with people who had done bad things, I guess. So I didn't think that big of a deal like some people would when they're in the hospital that have issues with people who commit crimes or taking care of them. Or I did have my son get in a car accident with people that were driving, and they flipped a car. And one time they came to the hospital, and I was like upset at the driver and was like, if I have to do their x-ray, how would I be wanting to treat them? I ended up having to do the person's x-ray, and I felt bad for him. He had a really bad break in his leg. But at first I was telling people I work with, you might have to do the x-ray when they get here because I'm so upset. And I thought I would be mad at the kid, but in the end.
Isn't it like a conflict of interest if like your family's involved or something? Like you can't do it?
You can x-ray your family. It's up to you if you feel like you don't feel like you could maintain composure, I guess, during doing it. Like if it was my child that was hurt, I don't think I would want to x-ray them because I might be upset. But I've x-rayed my daughter when she had her elbow dislocated. She was 2, and her dad like grabbed her by the arm on the stairs because she almost was going to fall, and it dislocated her elbow. And we didn't know that was what was wrong at the time. We just know she was crying and hurt. So we took her, they brought her to me, and I had to x-ray her, and it was fine. And actually in the process of doing the positions for the x-ray, it popped back into place. So she was fine afterwards.
That's awesome.
Yeah. So on page 304, there's some bullets. These are things that you want to do, similar to what we did last week with problem solving. Identify the problem, develop alternative solutions, select the best solution, defend your selection. So same thing. Problem solving techniques. So we looked at the ethical theories as we went through the little index in the front of the chapter. So under ethical theories, they're listed again and talking about them more in detail. So you have consequentialism and non-consequentialism. Those two kind of are opposites of each other. Consequentialism is that the rightness or wrongness is going to be assessed by the consequences at the end. So the least harm is the best outcome to pick. But non-consequentialism means that it's just the right or wrong thing to do. Whichever one is right or wrong, that's all they believe, regardless of the outcome. And that's probably situational based, but also yourself, how you look at things. So we don't get to make those decisions too often. It's probably doctors that are facing these dilemmas and decisions in patient care situations and what they want to do or how they want to treat a patient. So lucky we don't have to think about those decisions too often. Trying to look. And then later on in the reading, you'll see beneficence, non-maleficence, autonomy, veracity, and fidelity. There's a chart, table 24-2, that's got everything in it all together. So if you want to kind of use that as a study guide, that's good. Because most of the time we'll either have matching with the definitions or a question describing it, and you have to pick the right choice to see if you know them. Yep, the purple box, page 305. I thought I saw, like I had a message that's got me doing a private message, so I didn't know if somebody had a question. I was just looking back for a second for that. So now we have some relationship things that are going to happen, and we're going to talk about them. And there's a lot of cases. I'm trying to think. We want to do groups again and see what you think you would do. There's 7 groups, so let's do that real quick. Give you guys a few minutes to talk about them and then come back and discuss them so we don't have to sit here staring at our screens at each other for me to go over all of them. If I can get the rooms to work. So if you're in breakout room 1, you're going to do the situation case number 1. You got room 5, you're going to do case number 5. And now it should ask you to join. You don't have to act, just discuss today. Are you not in a room? Did you not get to go to a room? What happened? Eric, are you there? Did you get kicked out of your room? Why is it not letting her in? Marceli, are you in here? Trying to connect now.
I am so
Hey, there
sorry,
you are.
Professor. Yeah, I lost you guys and I couldn't get back in.
So I know I kept accepting you. Which did you get to a breakout room?
That's when I hit OK and then I lost everything.
Do you know which group you were going to?
It says here the host has opened breakout rooms. Please wait to be assigned.
So let me assign you to number 7. They only have 2 people. It's Aaliyah and Terwala. Let me try to figure out how to get you to go there.
Okay.
Put in the waiting room. No, I don't want to do that.
Do you think Nurse Smith is abusing drugs? Uh-oh.
Oh, here we go. Assign to 7. All right. Try clicking it now if it'll let you.
It says join.
Hey, guys.
Hey, I know you.
Which group were you guys? Number was?
Yes, number 1.
Okay.
So Miss Love, I don't know. Like the first couple questions, I realized that like maybe missed like one whole letter in radiographer. 'Cause I was
You typed it. You're fine. You'll be fine.
I was like, oh, I should have just put R. Duh.
If you wrote like xylophone instead of radiographer, then
And my brain was like, oh, you know the answer. Typed out
You typed it
everything.
real
And I'm
quick.
like, I could have abbreviated everything. I'm like, man, I was stuck on spelling everything correct. Still misspelled.
That's funny. I'll be back. I'm going to go to check on.
Okay.
Ashley, do you want to talk about it? Or you want me to talk about it? Or
I'll talk about it.
put it in our group?
You got it.
Do what?
I don't care. We should do rock, paper, scissors.
Oh wait, Caitlin's got to be in on this too.
What the? No.
Then you got to decide if it's
We're talking
rock,
about-
paper, scissors, shoot, or rock, paper, scissors.
Rock, paper, scissors.
Rock, paper, scissors, shoot.
You have to do the shoot.
You have to do this.
We're trying to decide who's going to talk about it. Ready? Rock,
Okay, we
Paper,
Timer
scissors,
is
shoot.
what?
Are we going one at a time, or are we all going at the same time?
Do it at the same time.
Yeah, we can do one at a time, or else I know.
Yeah, just wait at the last second and do it.
Everybody has to be on camera too, so you can see everybody's hands.
Okay, one,
I can
two,
see
Two,
Ashley.
three. Rock, paper, scissors, shoot.
I did paper.
All right, Ashley, let's go.
Okay, 1,
Ready?
2, 3.
Rock,
Rock,
paper, scissors, shoot. Oh, wait. Wait, was that who?
Paper covers
that
rock.
means I have to go.
Oh, wait. Okay, so.
Well, but
if you-
Caitlin
so
lost
you
the first
won.
one.
Caitlin lost
Yeah,
first,
so technically
Caitlin should
I beat
go.
Sarah on the first one, and then I lost to Ashley. So I'm
Okay, what's going on? I'm over here like.
Everybody's doing
We both did scissors on the first one. Scissors cut paper. So Caitlin
So
lost
Ashley and
first.
Caitlin go now, and the loser does it.
There you go. That's it. Yep.
so I gotta
Okay.
win. Wait, I gotta lose to not go.
You want to win to not
I
go.
win to not go.
I
If you
guess.
lose,
I gotta find your video, Caitlin. Where are you at?
I know I'm on my phone, so I'm like trying to look.
Oh, okay, I found you. Hold on, I gotta pin you. How do I do this?
Oh, look at Caitlin with the braces. Oh.
I'll put you two beside each other.
ready,
There.
Caitlin?
Yep.
1, 2, 3. Rock, paper, scissors, shoot.
Oh, Ty. You gotta do.
Tie. Okay, try
Oh,
again.
man.
1, 2, 3. Rock, paper, scissors, shoot. Oh, I love it.
I won.
Ashley was doomed from
So
the
now
beginning.
Sarah has to do it.
what? No, I won the first time.
Now I go.
I know.
All right, so everybody back now, and you guys were group one.
No, we're group two.
Number 2.
Okay,
Well,
so you
we're
don't have to
group
go
one.
yet.
We're group one.
Gotta try to get rid
Wait,
of.
Michael's in group 1? How does he get to
Because
go
of
first?
acting Is gonna
I
Are
thought
you
we were
presenting,
breaking-
Michael? Is that what's happening?
Well, yeah, weren't we in breakout room one, and we
Yeah.
do the first one?
Yeah, but with your acting skills, we just were saying that's unfair for you to go first. You need
You
to
get
be
deep
very
last
last.
every time.
I didn't know what I was going to do.
We're not supposed to
There's a
have
high bar set for you now on performing.
Even if we don't have to act it out, you still have to act it out.
Exactly, Michael. Let's get in character.
Michael, you can't start something and not finish.
Exactly.
He instantly starts looking around for
Like,
He's
what
looking for
prop can I
props.
use today?
He's over here panicking, guys. Like, where's my dummy at?
he went away. That's what he did last time, and then he
Oh,
came back with
Then he
the
can't. Yep,
head.
it's coming. Be prepared.
He's gonna come back in like full clothes and pretend
He's
to
gonna
be
be
the
on a
doctor.
doctor's
He's
cap
gonna,
coat.
yeah,
and
he's gonna
everything.
get scrubs and. Wait, what is their thing? Do you think my doctor is doing the right thing?
Wait, does one of my other group members just want to read that?
Since he
Haley
is
or-
doing all the props and all.
I'll read it.
Okay.
I'm reading a green box for number 1. Do you think my doctor is doing the right thing? Mrs. Brown, a 27-year-old patient of Dr. Smith, looks apprehensive as you begin your radiology procedure. Mrs. Brown found a lump in her breast and is worried about the possibility of having to undergo a mastectomy.
You got it, mastectomy.
Okay. Your mammographic examination reveals that Mrs. Brown probably has a small fibroid cyst. Mrs. Brown confides to you that Dr. Smith has mentioned the possibility of surgery. You are also aware that given a choice, Dr. Smith nearly always operates. As you conclude your procedure, Mrs. Brown asks you whether surgery is indicated. Adding, do you think my doctor is doing the right thing?
Ooh, that's a hard one. Does it say you think that he's good or not? Not really. It doesn't say any of that, does it?
Well, Mrs. Brown, or I guess we are simulating that she just asked. Do you think my doctor is doing the right thing? Well, I'm going to suggest to you that you relay that question to Dr. Smith, and if you don't feel comfortable or anything, maybe ask for another doctor's opinion, a second opinion. But that's going to be a question for Dr. Smith. So.
Yep. That's what a lot of groups come up with for that one.
Yeah, that's what we agreed on.
Good decision. Because what if you didn't think he was doing the right thing? Is that your place to tell her that, really? I mean, we're not
No.
doctors.
Yeah,
can't
even
say-
like in the book, it was saying even if we tell the complete truth, it could cause a rift, and it's just not necessary.
Yeah. Group number 2. All right.
Sarah, if you want to like read it, then
I'll read the box. Ours is about maintaining patient confidentiality. The image you took of Mr. Gray does not look good. As a matter of fact, you overheard Dr. Jones mutter about the advanced stage of Mr. Gray's condition. The transporting aide wheels Mr. Gray back to his room and returns with your next patient. The patient slips behind the screen to change into the examination gown and is out of earshot, quote unquote. Mr. Gray seemed real depressed. The aide volunteers, how did his films look? Does Mr. Gray have cancer? The aide is a good friend of yours and always has always seemed committed to good patient care. How do you respond to this?
So we all agreed that in this case, it's none of the aide's business to know Mr. Gray's information on whether he has cancer or not, and that we would probably, because it's our friend, we wouldn't want to like be like, hey, this HIPAA violation, I can't tell you anything, but we would probably just kind of play it off like, oh yeah, you know, like, I don't know, leave it up to the doctor, like, walk away.
Yeah.
Just try to like shut it down from there. Not be like, oh, I can't, I can't tell you that, but just.
I mean, that wouldn't be a bad thing to say. You could say that too, but yeah, play it off to the doctor. I don't know. I'm just an X-ray tech. That's what we say to patients. Yeah.
Like, I know
And that
nothing.
happens. Like, we had a really good transporter at one of the hospital, and they were like always wanting to ask about X-rays and stuff, and it was just like to a point where that's not any of your business. You're just supposed to be bringing the patients in and out. And it was weird because then I think they actually moved them and they weren't allowed to do X-ray anymore. because they were too busy always trying to figure out what was going on with the patients. Number 3, that one was a weird place for the box. Number 3, can we connect? Right under box. Number
Yes, I had 3. So for that one, I was by myself, so I'll just read it. It says you have performed multiple imaging procedures on Miss Gold over the course of her stay in the hospital. During this time, you have developed a friendly rapport with Miss Gold and often spend a few extra minutes chatting with her when you have the spare time. She tells you that she is being released from the hospital the next day and asks if she can connect with you on a social media site. How do you respond? Me personally, I've had, because I'm a CNA, so I've worked in the hospital, and, I do like to talk to people, so I've had this happen to me. So me personally, I don't add them on any social media, I'm very particular about, my social media, so I don't just add any and everybody on there, so I keep work, personal.
What do you tell them when they ask that?
But well, I kind of play it off and be like, oh, I'll be right back, or I'm gonna grab this. They usually ask for things, so I kind of change the subject a little bit, when they would call me into the room. So they like, we get to talking, and they're like, well, I'll go grab the ice for you. And then by the time I go grab the ice, I got another room I got to go in. By the time I come back, they've forgotten about it. So I kind of just play it off a little bit, like, I'm gonna change the subject, but yeah.
It's just like, I don't get on there very often.
Yeah.
I don't believe in computers.
I don't know. Me working, I work corrections and as a police officer, so I never gave anyone my social media. I don't even use my name on social media. So they'll always like, and I have, inmates that was being released, and they was like, oh my gosh, like, I love you so much. Like, can we link up? And I'm like, and I was so honest there. Yeah, and I'm always like, oh no, I don't mix my my business and my personal life. And it was like, oh, really? And I'm like, yeah, like,
business really? First, business always.
Yeah, and I never had an issue. I did have some people that like randomly find me, like, especially like when I was a police officer, it was like they'll just randomly inbox me, and then I'll message them back telling them like, hey, like, and then I'll block them.
Yeah.
Yes, stalker person.
They can find you.
Group 4.
Okay. I think Dr. Jones misread the image. You have finished a routine radiologic procedure on Miss Green. As you process the image, it becomes clear that Miss Green probably has a rare form of bone disease. Dr. Jones, a young resident, glances at the image and smiles. I didn't think Miss Green had anything to worry about, he says. That joint pain she was complaining about must have all been in her head. Later, you see Dr. Green talking to Miss Green's family. He is smiling and joking with them as he signs Miss Green's discharge papers. Shaken, you mutter to yourself, I think Dr. Jones misread the image. What actions, if any, should you take?
We decided as a group that the action we would take, we would let the radiologist know that we think that the x-rays were misread, and then just have him deal with it.
Yes, exactly. The resident could be a radiology resident, but he could also be an internal medicine or an emergency medicine doctor, and residents don't really read x-rays, so going to the radiologist would be your best choice. Say, hey, Miss Green's getting discharged, and I believe he doesn't think there's anything wrong, but what do you think about this x-ray that I took on her? Is there something here that he's missing? Let him call that doctor and handle it from there. Yep.
A quick question on that.
Uh-huh.
If we were going to show the radiologist the x-ray, would we just have them walk to a computer and then we pull it up somehow?
Yeah, or if we're, and sometimes you're not in an area where that radiologist is actually at, so you have a number for the radiologist, so you can call them on the phone and give them the info. Number, what was that, 4? Number 5.
I'm part of 5. I just shut my book by accident to read. Let me get back to it. What page is it again?
307.
307. Oh, box
307.
24.5.
307.
All right. So ours says, in my opinion, you'll just be fine. You're assisting Dr. Rowe with a particularly complicated radiation treatment. Mr. Black has been on the table for nearly an hour and is clearly exhausted. As Dr. Rowe leaves the area to respond to a page, Mr. Black groans as you help him off the table into his wheelchair and begins asking questions about his condition. Is Dr. Rowe doing the right thing? I feel terrible. What do you think? Mr. Black has acquired the reputation of being somewhat of a hypochondriac. You are aware that Mr. Black is being treated for cancer and has a 50-50 chance of remission. Your initial impulse is to reassure him with a smile and say something such as, in my opinion, you'll just be fine.
So, like I said, in her opinion, you can't give, that's like giving, you can't say you're going to be fine because you don't know he's going to be fine. It's just a 50-50 chance. So you don't want to give false hope. So I just feel like you should just choose positive words, something positive to say. And, or hopeful words, something like, I feel like you're strong. You can do this. But I wouldn't
we'll be thinking of you, something like that. Yeah.
Yes.
Yeah,
Well, you're supposed to like take your emotions and your own personal stuff out of it. And by giving the opinion, oh, I think you'll be fine, it's it breaks that ethic part. You really should be like, oh, the doctor will come and see you shortly. Let's get you in a more comfortable room. I know you've been on that table a long time. Kind of just
And
like
also,
just shut it down and keep going somewhere else.
We don't know all the possible treatment plans for it. We don't even know the results yet. So that's something that you want to encourage her to follow up with her doctor for that, so they can give her all the options to make the best plan for if it is cancer back or not. And they probably already know that too in their head if they've already been through it once.
Yeah.
They're just worried and scared. I had a guy who came in 2 weekends in a row for a CT of his abdomen and pelvis because he just knew he had cancer. And he's like, I just know they didn't see it the last time. And I just came back in this weekend to get another CAT scan because I just know I have cancer. And I'm like having to x-ray the person. And he's like, well, what did you see? Did you see anything? And I'm just like, I can't tell you anything.
They say that all the time in MR. Hey, you just scanned my brain. What did you see? I just take the pictures. That's for the radiologist to read. Your doctor will follow up with you in 48
hours. I'm like, we just
hours.
have like 100 or more pictures of you, and I don't read them when I'm doing it.
I don't know what
I just
I'm
make
looking
sure
at.
we got everything there, and I'll be hoping for the best outcome, and let's hope that you don't, and send them back to the ER. But it was super weird. That guy was like adamant that he had cancer. Page 307, the last, no, we got one more after this, don't we? Number 6, group 6.
Okay, so me, Brooklyn, and Kayla had 6, and it's called What's the Holdup? You are a CT technologist working with the limited staff on a holiday when victims from a multiple car accident are transported to the emergency department. Dr. Williams orders a CT scan of one of the patients. During your assessment, you find the patient semi-conscious and somewhat combative. There is no one available at the time to help you transport the patient to the CT department. In your judgment, it is not safe to transport the patient until more help is available. Dr. Williams, anxious for a diagnosis, begins questioning your actions and demands you immediately perform the order exam. How do you respond?
So we talked about this one, and we decided that anything that has to do with a patient's safety, if we feel their patient isn't safe or is in a place where something could happen, like they could fall or get even more hurt, even though the doctor has a treatment plan and needs a diagnosis, we would seek other help, whether it's not just technologists, maybe it's a nurse or somebody who could assist us in moving the patient before we would be able to get the diagnosis to the doctor.
Good. That is exactly what you would do. You would tell the doctor, hey, I don't have any extra help right now. This patient's being combative. You want to come over and help hold him? And that's usually what happens. We had a guy in Gainesville. This place is for the mental, it's like a home for mental unstable people or people who are not even mentally unstable but have like Down syndrome and they don't want to live at home with their family. They put them here. It's called Taco Charlie. I don't know if anybody's heard of it or if there's a place like that in Jacksonville, I don't know about. But those patients were always combative. And it was a Panorex we were trying to do with the mandible to see if they had a break. And the machine, if you've ever been to the dentist and had that machine circle around you, while you're taking the x-ray, you can't stop it. Once it starts moving, it goes until it takes the picture. And the person would not sit in it. They were scared of it moving around them. And every time, and you have to hold your mouth on this little piece and not move your head. Every time it would start to move, they would like jerk their head and they were going to get injured. So we knew we weren't going to be able to do the x-ray. We couldn't get them to understand to hold still. So we told the doctor this like several times. We attempted it. We never got the picture to even move because every time we tried to put their head in even the holder, they would jerk away and like almost hit themselves on the machine. So the doctor was a resident. It wasn't an actual doctor yet. He said, oh, I'll come over and help assist and hold him. And we're like, oh, okay, you think that's going to work? My boss, she was like a real smart alecky personality. She said, sure, come on over and try. And like set it all up. The doctor's back there holding him with the chair and trying to lean back out of the way for the machine to circle around. Sure enough, him and the patient get stuck between the machine. He's physically holding it with his hand to not squish him in the guy. It was a nightmare. So, at
least they believe you now.
In an unsafe area. Needless to say, they did not get that Panorex. So that doctor was adamant that they needed that day.
In cases like that, I mean, is it possible to have them like sedated or give them like
sometimes we sedate patients
Valium or
yeah,
you know,
CT exams and
something?
MRIs, we give them some of that. For that particular x-ray, no, because
They have to have their mouth down
sit
on the.
up and listen and follow directions. There was no way to do that patient that exam. Alternatives would be to go through a CT and put them to sleep. Let him have some relaxation meds and go get his CT. Yeah. I think that's what they ended up doing too, actually.
That's not center.
Yeah. See, I don't think of these until you guys start talking about scenarios and they come popping into my head, all these things that I've seen. Number 7.
Okay. During your lunch break on the night shift, you decided to visit with Miss White, a patient with whom you have developed a friendship. Miss White's room is directly across from the nursing station, and she tells you that she has noticed Nurse Smith slipping medications from the drug cart into her pocket. You recall seeing Nurse Smith occasionally swallowing some pills while on duty, but you have thought a little bit about it up to this point because Nurse Smith is the only nurse providing patient care during the shift. You are concerned about the quality of patient care as well as Nurse Smith's health. Miss White asks, do you think Nurse Smith is abusing drugs? Your answer, I hope not. However, you believe that you must confront Nurse Smith directly. Despite your best effort to be tactful, Nurse Smith explodes. What do I do? What I do on this ward is none of your business. What do you do next?
Oh, this one's a good one.
Well, yeah, I was in that predicament, and what I did was I went to the DON. I went to the director of nursing, and I explained to her what I've seen, what I witnessed, and then I just stepped back, and they took care of it from that point.
Yeah, because you've already tried to approach her, and obviously that didn't go well.
It didn't go well at all.
These patients aren't getting their medicine. The nurses are taking it if they're addicted to it or they're selling them or whatever the case may be. So there's lots of safeguards now. There's lock key codes. Person has to put in to get the medicine out. And sometimes people even have to witness and double check, double key in at some of the things to make sure this is not happening.
What if, sorry to interrupt, whenever they're giving you medication, obviously like if it's like Ativan or something like that, they have to mark down and record. Can they like take like scan your bracelet, whatever, and then pretend like they gave it to you.
And give you
even though-
Tylenol instead or something. I'm sure that's some of the ways around it that people do. I don't know for a fact because I haven't heard of any cases because I'm not around that much. If you're working on a floor with nurses where it's happening, they're probably more privy to that information. But we are in X-ray, we probably won't see it as often unless we're pushing the portable by and just so happen to notice it, like this scenario kind of did. But that is one of the ways that people are doing that and abusing it.
Yeah,
I did work with a girl who was fired and was getting her nursing license back in process of it. She was having to go get drug tested every week. Whenever they called her, she had to go. And she was a good nurse. She just had a problem, a drug problem. And she was trying to work and get her life back together. And unfortunately, she was with an abusive guy and he burned her in a house fire. And her daughter actually went through the X-ray program that I was teaching at, and it was so good to see her go and get her degree, but it was a very sad situation. But yeah, she was almost getting off the medicine and everything and doing good, getting her life back together, and that happened to her.
Could you
You
go
know.
to rehab and not get fired and still keep your license? Like that would show proof that you want to change. But
yeah, I'm sure
you
there's
haven't stolen
programs for everything. Yeah, there's
So,
steps involved. Yep.
Well, we decided in our group that we wouldn't go to that person. We would probably let the charge nurse, just to keep the state out of it, let them know so that they can observe that information.
That's
person.
probably what I would do too. I wouldn't want to approach the person directly because that's never going to go good and they're never going to admit it.
No, they're not.
And I skipped the last one. A is keeping the matter between us. So you can read over that one if you want. Basically, you notice that there was an error made and the tech or whoever was like, let's not say anything, just keep this between us. So, of course, probably going to your director or something, we need to fix this for the patient's benefit because that's our number one thing, fixing the mistake. Which leads us into the chapter 25, which is our last thing we have to do today, guys. I know it's 11:30 and I don't know if anybody needs a bathroom break or to get something to drink or eat. It's almost lunchtime. I really think this chapter is quick and easy. We talked about it a little bit yesterday with the packs and the codes and insurance and things like that. That's really what it's all about. We want to vote. Do we want a 5-minute break? No break? Keep going?
Push through it.
I'll take
fast, super fast. Go.
All right.
Why can't
let's go through it.
I pull up my video like it's saying?
Oh, your video's not working? I think when you were done with your exam, I turned video off. So I guess it's still locked from that. Let me figure it out.
I just wanted to see if my webcam was still working.
Yeah, I think that's the same for another person too. Let me
I'm
find you.
going to turn it off anyways. I just wanted to just double check it.
Okay. Okay, see if that works. I just clicked a button. All right, so chapter 25 is all about the health records and health information management. We do need to know a little bit about that and how things are stored and charged. We talked about it yesterday somewhat, but this is the whole chapter dedicated to it. So now we are working with digital medical records, and every hospital you work at or go to, or any clinic you go to, is going to have a whole different digital medical record system. So you're going to have to learn how the clickable buttons and how they work are when you move from site to site. So it makes you really knowledgeable and flexible by doing that. At first, you're probably not even going to be allowed to access them because most of the time you're going to be doing exams and the tech's going to be doing all the paperwork stuff. I don't know why it's stuck big like that. So basically every single thing we do is logged into the patient's medical record or chart. From the moment they check in till they leave the hospital. So we need a place to store that. It used to be handwritten in papers and lots of filing was involved, and now it's all on a computer. We know about HIPAA a little bit. You got your HIPAA course you're going to do, but that's on page 312. The Health Insurance Portability and Accountability Act and then of 1996 kind of got dropped. So that's when it came into effect. It's a legal requirement for all medical documentation records to be kept private unless the patient releases that information to you. So it includes pharmacy information and doctor's office visits, anything medical. So that's why we have those little stickers now at the pharmacy and the digital keyboard that you sign for your medicine now, so that nothing can be released. I think CVS got sued when this first happened from not protecting patients' prescription information. I think they put it in a regular trash or something and it got leaked out. Lots of lawsuits have come from the HIPAA Act. Movie stars' medical records getting released and things like that's another one. Lots of child custody type things where people were hiding records and things like that, or not releasing them to the right thing. So lots of reasons for it. And also to protect us at a job, you no longer have to disclose your information to someone if you're sick at an employer, unless you want to. The PPS system, that is the government system to get paid. So we talked about third-party payers in the last chapter. Medicare, Medicaid is the government's reimbursement system to the facilities. So the system is called the PPS system. You have to put in a diagnosis code in order to match the reason for the exam to get reimbursed. If the codes do not match, then you're not going to get the reimbursement to your facility. So we talked about that a little bit too yesterday. So a chest x-ray has to have a reason for a chest x-ray. And if we do a chest x-ray and we don't have the proper reason and we put it through and the doctor reads it and the reason wasn't the right reason, we won't get paid for it. So just having a fever was an example that they don't pay for a chest x-ray if you just have a fever.
Would that be a medical error? Or
I mean, it's kind of a medical error. It's not like we did something wrong. That's just what they put on it. But what they've done to us as techs now is told us in certain departments, a big deal was made about it for so much money loss that they're trying to make sure we are aware of that. So we need it to say chest pain, a cough, fever with suspicion of pneumonia or some reason that will qualify for them to be able to do the chest x-ray. So of course that goes to the front desk people first, or the nurse that's ordering it. And we can't just put in and make up a reason. We can take a history and add that in our notes for the doctor, but we need to call the ordering person and tell them they need to fix that. So that's the only part of our job there, because that's where that information comes from, whatever was written on the doctor's order. We talked about the Joint Commission yesterday. That's on page 312 under patient record. So I did Google it last night. JCO and Joint Commission are the same. Just some people call it JCO. I was like thinking about it. That's the biggest kind of accreditation for the hospitals. So there's other accreditations out there, but that's the main one you'll hear about. So the electronic health medical record, that is what we use to store our patient's information. Radiology reports go there. X-rays are part of the medical record, but they're stored on the PACS system. So that's a separate health system. So the electronic health record is where all the typable words go. That includes patient identification, name and address, their insurance information, their medical history, any reports from exams that they have done, lab results, and diagnostic x-ray results. Anything that they get therapy-wise, what the doctors and nurses observe, all of that is going into their medical record. If we do a thing called an informed consent, that's going to be in there. I think this is probably the chapter we want to talk about informed consent. It's not talked about a lot in this book. I will find some more information and add that to our course next week for you on that, but it's a little italic word here And this is a big thing for us. So informed consent is probably gonna be a question you're gonna have. What is informed consent? So it doesn't go into big detail on that, but basically any type of procedure that is going to require invasive, possible reactions, possible harm to the patient, they need to be aware of that before we do it and sign off on it and say that they've been told of the risk and the benefits of the procedure and they are agreeing to have it done. So this prevents medical errors of the wrong leg being cut off, like some of us were talking about yesterday in our group, that they know that they could have a high chance of an infection if we do this. So for us in radiology, it's going to be anytime we do an injection or poke a needle into a patient with an arthrogram or a myelogram where we're looking at the joint space or something, because that can also cause an infection or possible paralysis into the spine if they hit the wrong area of the spinal canal. Could cause, in some instances, death is a risk if they inject air into an area where they're not supposed to. So those are things the doctor's going to come in and talk to the patient about before the procedure. We are just there to have the paperwork ready and sometimes sign as a witness on the informed consent. Anytime we inject contrast media into a patient, we get an informed consent signed. We also have what they call implied consent. I don't think that's on here, but just by them coming in and we telling the patient, we're going to do a chest x-ray today, it's implied that they're acknowledging that we're doing their chest x-ray. So informed consent is a little bit step up for things that are a little more invasive. Any surgery, you've done this before when you've went in for a surgery. You've signed that form. It's now digital too. Sometimes you can sign on a keypad.
What is it when they come in like unconscious? Is it a family member has to do it, or is that go under like implied?
An attorney or a family member can sign for someone who is either mentally not able to, like dementia patients and things like that. Their family member will sign for them. Yep. We've actually had to do it by the telephone one time at the office I was working at because the patient came from a nursing home and was not able to sign our informed consent. So we had to do a verbal consent with the doctor over the phone with the family member. And it took forever to get a hold of them.
So implied, is that verbal only?
Yeah, well, implied is something that we consider anything that's where it's not needing to be signed off on and written, that they're consenting to us doing the exam. So when we bring them in the room and we say, Mrs. Jones, we're doing a chest x-ray today, and they're like, okay, yeah, that's the implied consent. We don't have to get anything written for that. So radiology, we always have to have an order before we do the x-ray. That's the health record in radiology. So anymore digital, it's almost impossible to do an x-ray without an order because we have to have something in the computer system. It used to be a friend of a doctor could slip their friend into the radiology department and say, yeah, my son hurt his arm today, can you do an x-ray? And we would just do a favor and do an x-ray. That doesn't happen anymore because it's digital record of it. So you have to have an x-ray order. So in some circumstances, a cardiac arrest patient coming in through the trauma, they don't have time to get the order in the computer. We'll do it under anonymous and we'll go back in and put the patient information in after we have it. So there's loopholes in the digital system to be able to do exams without the patient order first, but we like to have it. That way we don't have any mess ups in the computer part of it with putting the patient identification in. Has to have the name, a health record number, medical record number, and any other identifying information as far as that it was a chest x-ray, whatever code they put on it to identify that. The procedure being there, the name of the procedure, the physician ordering it is also on every single x-ray. So patient's name, their medical record number, and that's in parentheses under the health record and radiology. Some sort of identifier, normally a chest x-ray will have a code assigned to it for that patient. So if it was their 5th x-ray they've ever had, their number might be 3305. Then their next x-ray they have would be 3306. So there's an x-ray number associated with their x-rays too. The name of the exam and then the patient's name. The physician's name on there, whoever ordered it, is also on the x-ray.
Just a random question. If someone comes in to do an X-ray and they've had like 10 prior X-rays, is it going to be known to us like they have a bunch of previous ones?
Usually
Or-
we can pull up their radiology record in the digital system in the
Okay, yeah.
PACS. Yep.
Okay.
We don't necessarily look it up unless it's a reason though. Something that's not on here that's odd, usually the date of birth is on there. Doesn't say it has to be though, but it just says patient's name.
What it is like an identifying thing because there could be
Yeah,
12.
that could be it. Because we usually see the patient's age on our x-rays, so the radiologist has that information. So after we do our x-ray, we close out that exam. We start it when we begin the exam, we close it out when we're done in the digital, the medical record chart, so that the chart sees that there was an order put in, sees that that was done, and then the doctor's going to dictate it and read and give a report on it. So all that should flow in the medical record chart. We have to have a reason for exam, so that has to be in there in the order section. And that's where the numbers are going to come in when we talk about coding in a minute. There's every single diagnosis has a code with it. There's this big old thick book. We used to just go to a Google site and find those codes when we needed them, but you sometimes do have to put those in. It might say cough, but we can't put cough in for the code. We have to type the code for cough. There's a code for high cholesterol that you have to put in for lipidosis. There's a code for back pain. Every single injury thing has a code. I didn't have to deal with coding until I worked at a doctor's office. And then when I worked at the hospital in McClenny, we had to do coding sometimes. Most of the time in big hospitals, you guys are not having to worry about all the billing and coding. There's a person dedicated for that. Page 314 shows a sample of a report. It has the patient's name, the exam on there, and then what the doctor found. And at the very end of the report, it will say impression and what the main impression was that the doctor. Sometimes it'll just say normal. They didn't find anything wrong. But the impression, if you ever have to give the ER doctor or the physician the report, that's usually all they want, is whatever the impression was over the phone. So payment plans, we talked about that. On page 315, ICD 910, that's the codes, that's the coding system. Page 315 in bold blue. So if you work in billing, you're going to start memorizing all these codes and know them. Each
And they
exam has a,
change.
it's not 10 anymore?
No, it is 10. I'm saying like they change, like the codes change all the time.
Yes, they all the time change them. So that's why this says the 10th revision. It's probably changed since this book was printed. But that's why we just Googled the most recent coding when we were trying to find codes. But just so you know, the term ICD-9, if you hear that, that's the codes for billing that we need to use. Everything has a code. Thought they had some samples of them in here, but I don't see them. It does say on page 316, the function of the codes. It says the code numbers range from 710 to 79999. That's for radiology exams. So each exam has a code. You don't need to know that number. I'm not testing you on that. Just kind of how they group things in the number order of it. When you start having to deal with that when you work somewhere. We talked about that performance improvement the other day that the hospital requires. The Joint Review Committee requires the hospital have a performance improvement plan. That's one of the committees that they have, that performance improvement committee. So they look at that when they come in and assess them. What are the things that they are trying to improve in their facility? And then they have to chart it and collect data on it, whether it's malpractice lawsuits, infection control rates for certain pathologies that they were high at the last year. Patient satisfaction might be something they want to improve on, getting more surveys back with happier patients, whatever it is, and then they'll collect that data throughout the year. So for us as techs, this is important to know because our department may be part of this and they might ask us to collect data or something in relationship to how we're going to help improve it, whether it be the infection thing. At Shands, when I worked there, we had a big infection happen in the burn unit. All the patients were getting it and they were trying to figure out why. Well, we already had our own portable there. We already gowned up in full protective equipment before we went into a patient's room. And they ended up taking, it was something with the ventilation, taking and redoing the whole unit. They also had something happen on one of the floors where every patient was getting MRSA and they were trying to see if it was from a doctor, from a pen. Every room had to use the same pen. You had to wipe down everything in and out of the room when you come in and out of it, which probably should be done anyway. They tracked that down. The infection control people tracked it down to a transducer from an ultrasound machine. It was the cord was spreading the infection. But these are things that you may be involved in helping with, collect either the data or help and improve your care and service to stop these infections or whatever it might be in their performance improvement plan. So the Joint Review Committee requires that hospitals have this. That's about it. Legal stuff in the last section. We have HIPAA, big one. There is not important as much as anything else here, this privileged communication. Physician-patient privilege. Physicians can talk to another physician about a patient's history if they're getting help from them on the case or something. So they don't have to have written communication from the patient to do that within the facility. But if they're going to an outside place, another doctor's office or something, they probably need that written consent. We have to have it by fax and written. Even if it's the patient coming in for their own copy of records, they have to sign for it and fill out that paperwork. We can't just give it to them, even if you know them. And we have to have an ID verified, even if you know them. We used to have to scan in the IDs. McClinney's a small town, everybody knows everybody. But we still were required, and people would get so mad. They didn't have their license with them. They left their purse in the car, whatever it might be. We cannot fax anything without the written consent according to HIPAA. Information security is a big thing. We have lots and lots of passwords, timeouts on the computer screens. We can't leave the computer screen open. Big no-no. You can't bring patients back with other patients' information on the screen. Everybody wants to come back and watch the x-ray, and we can't because other patients' information's back there. Health record in court. If you're working at a small place, you may have to help do this, but we do not give them the originals. They always get copies, which isn't a big deal anymore because everything's put on a CD or sent digitally anyway. But it used to be the medical chart had to be physically copied on a copier. The x-rays had to be taken into a room and made a copy of on an x-ray copying machine. So it was a bunch of work for us.
But we don't have to do that because a lot of times they have an outside person come in and do it.
Oh, that's nice.
Yeah. I know when I used to work for pulmonary and critical care, they used to have like somebody come once a week to scan in medical records and
oh, interesting. Yeah. The big thing about that is they bill like $5 to $10 a copy.
Yeah, they do.
The lawyers, that's where they bill the patient or their client all that copy money. But now it is much easier because it's all digital. So health records are a legal document. That's why we have to have our markers on our x-rays. You can be brought into court. My boss at McClinney was actually brought into court before for a case. Of course, they're going to sue the big money making the doctors, not us, but we still could testify. That's why marking the correct side is important. It's illegal to not have a marker on an x-ray. You can digitally do it now afterwards, but legally we have to have our marker on there. But we'll talk more about that later. I think that's it for today, guys. Thanks for sticking it out with hardly no break, taking your exam and just pushing through, guys. I hope you got a little break after your exam, at least to go to the bathroom, because I have not. I've been sitting in this chair, my butt hurts. see you guys on Tuesday. Do not come to the live on Monday. I won't be here. Any questions on anything?
No exam Tuesday, right?
No